to the Patient Perspective series featuring Will's Power Foundation. We're very lucky to have our special guest today, who will be giving us a very important message, especially for those of us in research and in healthcare. And I find that their story is very enriching and heartwarming. And so I'm excited to listen and to have you all participate as well. You can put your questions in the chat, and Greg will direct them to the speakers. And so, Greg, do you mind introducing our speakers today?
Yeah, so thank you everyone for coming tonight, for listening to our Patient Perspective, yearly Patient Perspective series. So we're joined today by Will, Jen, and Kevin. And I won't say too much. I know you have a really amazing story, so I'll let you say, but we've been in contact for a while, and I think that we've had really great conversations, and their journey is really amazing. So I think that we'll be able to take away a lot from their talk today. And again, as Michael said, if there's any questions, you can either put them in the chat and I'll read them out, or you can send them to me personally. I think, would you prefer keeping them for the end, or we'll kind of go with the questions as they come?
We'll keep them till the end, I think.
Yeah.
Probably best.
I'll compile them and then we'll do a Q&A session at the end.
Sounds good.
So you have the floor. Thank you.
All right. Well, we're going to share our screen at this point. Hopefully this works. There we go. Okay, let's start that. Okay, well, thanks for taking the time today to listen to our talk. Just as a little background on us, we live in Canada with our 4 kids. Needless to say, we have a busy household on top of managing a rare disease. As parents of a child with a rare disease, we're really quite thankful there's a group within the greater medical community who's interested in learning more about rare diseases and the challenges that are faced by the patient, as well as the patient's family when navigating the life-altering journey that a rare disease becomes. We hope in this talk you can learn a little bit more about our child's specific rare condition, and from a parent's perspective, you may gain some insight as to how you can maybe best approach other rare patients that you may encounter during your career. Before I go on, although this talk may sound a little negative at times, our experience as parents of a child with a rare disease is not unique. But we can't understate enough how forever grateful we are for all that's been done for our child. We've watched him close to death many times, and without the medical teams that have aided him so far, he wouldn't be with us today. Our journey is quite long and unknown, but we do believe the best intentions have always been behind those who've cared for him.
We truly hope that some of you have the opportunity during your careers to care for a patient with a rare condition. You will mean so very much to those individuals, and you have the capacity to greatly improve the quality of their lives, and by extension, those of their families. Please let us know if you have any questions, and we would love to hear from you after the talk or through our email, and we'll post it at the end of the session.
So in tonight's talk, we're kind of hoping to provide an overview of our medical journey with our son to date, the specifics of his rare disease, and finally, a little discussion around our own perceptions as parents of how medical teams benefit a rare disease patient.
So our son was born in 2012 with a lymphatic malformation on the right posterior triangle of his neck that extended up the base on his right mandible. This resulted in his neck being displaced to the left side by the swelling above his right shoulder. This was not detected on the 20-week ultrasound and likely developed sometime around week 30. Had it been detected, he would have been delivered by cesarean at a larger hospital. His lymphatic malformation was successfully treated using sclerotherapy at 3 months of age with a bleomycin injection. And this caused the large cyst to sclerose, leaving microcysts with the ability to swell at any given time. But overall, the macrocyst collapsed, so that allowed for the correction of muscle function. There were no concerns, especially as far as his head posture and his breathing went. And he was followed closely for 3 years with regular checkups that included ultrasounds and manual palpation of the area. So as we see here in the first slide, his hygroma was quite big on his tiny frame. So his head was always cocked to one side. And then he grew into the mass a little bit, as you see in the second picture, but you see the pronounced asymmetry in his face. Over time, this got better with treatment. And you see here, this is right after the treatment, and it collapsed substantially. We had initially, after 2 weeks post-treatment, we saw swelling of the site and then a gradual shrinkage. And over the next several months, he grew into this loose skin right here. except we had a little blip at 18 months where he got a common cold and it swelled up to look and feel exactly like a golf ball. And then over time, we see it disappeared completely and he looked normal.
So something that we probably should highlight just before we go on is that kids that are treated for lymphatic malformation, such as these, should probably have some of that affected tissue harvested during any treatment from the site itself. And it should be set aside for some kind of future testing. A big obstacle with our son's diagnosis in terms of the genetic basis is that these cases require affected lymph tissues. And we've learned as we've gone through this journey that can be very difficult to obtain. Such genetic testing offers the benefit of a patient-specific targeted drug therapy rather than just a trial and error when it starts. So anyway.
So before the age of 7, he developed completely normally. He attended regular school with no special learning needs, was always at or above average for grade level. He was a very quick learner and very athletic. He was on the travel soccer team in the summer and he played hockey in the winter. Without the hygroma, like I said before, he looked completely normal. But as parents, we had a feeling that things weren't quite right, and these differences did not sit well with us. He continually had back pain, and we were told to change his pillow for sleeping. He had a characteristic odor that smelled like mothballs no one could explain. We tried to get to the bottom of this by taking him to our family doctor and several dental specialists, as it resembled a sinus infection type smell, but no one could help us. He was very pale, and he had dark circles under his eyes, despite sleeping well. This was explained by, oh, that's just the way he is. And when we were told to relax, we're being uptight because of the way he was born. He looked different than his brothers and sister, and he was much thinner. Again, we were told, relax, that's just his physique. He had boundless energy, but then he would crash hard and lay on the couch. He's always to bed the earliest, and he slept the longest. He began having reoccurring headaches in 2019. So we decided to further investigate this, which was done through an MRI by a pediatric neurologist and a lot of blood work, and everything came back normal. So we breathed a sigh of relief until the fall of 2019 when things started changing.
So, we're not sure if it's really related to his illness or not, but in October 2019, our son was bitten by a black-legged tick and it required removal at our local ER. He was given a single dose of doxycycline as a prophylaxis. The tick was later evaluated by public health and was negative for Lyme, so for what it's worth. But 3 weeks later than that, we had a pneumonia running through our house. Our son went to hockey the first weekend of November. He came off the ice not feeling well. After a couple of days home, he went to bed with a fever. And the next morning, his fever couldn't be controlled with children's Advil and Tylenol. He was totally lethargic. But most importantly, the cyst in his neck had just reappeared, and it was swelling rapidly. Before noon, we went to our family doctor. We were advised to get to the nearest children's hospital ASAP. Increasingly, he was having difficulty breathing. When we got to the ER, he was slumped over in the car seat. And basically from there, the medical odyssey began. Soon came what felt like a revolving door of medical students, residents, fellows, respiratory therapists, surgeons, and physicians, along with a parade of ultrasounds, blood work, chest x-rays, MRI, CT scans. As the teams switched off, as his ER admission lengthened, it really became so hard to keep track of who and what everything actually meant. Within 24 hours, he ended up on in the ICU on a ventilator after the placement of bilateral chest tubes to manage his pleural effusions. This was incredibly hard to witness and even harder to explain to his siblings. We quickly realized both how sick our child was and also the inherent difficulties of being a parent of a child with a serious illness. Our daughter was only 6 months at the time and she was still nursing. His brothers had to get to school the next day, and apparently we had to find somewhere to sleep. The family unit really becomes a house divided when living at the hospital.
So in this first slide, we see the hygroma reappearing, and this is in the doctor's office. This was within the hour. His neck swelled this much right across the front, and it's really angry and red looking. And this is after antibiotics had begun. So we still see it's a little bit red here, but the swelling in the front of his neck had subsided substantially.
So blood cultures that were taken indicated a pyogenic group A septicemia. And then he also had culture taken from his malformation site. That indicated a separate group B strep infection in the remnant of the cyst. He spent an additional 2 weeks in the hospital, which was managed principally by the surgical team with input from infectious disease for the antibiotics to clear the effusions. The drainage from his chest tube gradually transitioned from a pneumonia type of exudate to a chylous, non-flowing fluid with very little drainage. And just as an aside here, if you ever have the chance of doing chest tube removal, on a child, It's a crazy procedure as a parent to watch, and maybe it's a story for later, but despite what they tell you, it definitely hurts. But anyway, so he was discharged and he was sent home with a relatively clean bill of health, despite he had new onset of abdominal pain. It was attributed mainly to his high dose of antibiotics when he was in the hospital. He was on vancomycin and quite a few other ones, cephalexin. We were told his lungs would eventually clear the remaining fluid, but they never did. Just over a week later, he was readmitted, this time for a right-sided pneumonia pleural effusion. And it was probably secondary to the bacterial infection from his chest tube site, and it necessitated a second chest tube on his right side. Again, this chest tube drained very little fluid and only drained chyle. After just over a week, the chest tube was removed and he was basically sent home. We were feeling rather uneasy about the lack of clarity, but from the whole month of being in the hospital, we were exhausted and we were just happy to be leaving. He came home for Christmas. He slowly recovered. He was able to briefly return to school and tried hockey a couple times, but he always was complaining of breath, and he complained frequently of an upset stomach.
So we'll just go over this slide here. This is the pneumonia with fluid that came out. So it was usually a yellow or a red or an orangey tinge. And then we go into the chyle and it was a yellow whitish, but you can see the chyle up close here. It looks like milk in the tube. And then this is when he was placed on the zero fat diet. And you see, this is just an air bubble, but here it's not milky anymore. It's just like a clear liquid that's coming out.
So as everything was getting closed down because of COVID in 2020, our son really started deteriorating. We picked up a pediatric pulse oximeter on Amazon, and at home we were watching his saturated oxygen all the time, which was declining steadily. Aside from shortness of breath and lack of energy, he developed a strange gait at times, kind of gangster-like. Then he started complaining of bubbles in his neck when he was swimming once we finally opened the pool. So when the healthcare system reopened, imaging in June 2020 showed a real pronounced reaccumulation of the pleural effusion on his right side. We were hesitant, but we consented to another right side chest tube at that time, despite the limited success of the process 6 months earlier.
So this is images of his chest x-rays. The first one is a normal chest x-ray, which I pulled off the internet since we don't have that for our son. Next, we jump ahead to June 2020, and you'll see here the accumulations on the right side, primarily up here. And then you jump a year later to the June 2021 admission, and all of a sudden it switches to the left side, and we're still not sure why that has happened. This is his most recent x-ray of May 2022, and we have not seen this at all during the course of his disease, the gradual clearing of the fluids. So we are remaining cautiously optimistic at this point that the new drug therapy he's begun may be making an impact.
Okay, so just back to where we were in his disease process here. Basically, when he was admitted in 2020, we had very little fluid coming out, just chyle coming through the chest tubes. So we tried several rounds of TPA flushes through the chest tube to try to break up the effusions. He had further imaging, which included a CT scan, ultrasounds, MRI, and it was finally confirmed to be a chylothorax. And some of the MRI findings actually found some irregularities in the spleen. The working diagnosis at the time became that of a lymphovascular malformation, causing a thoracic duct leak, causing the pleural effusions. In order to manage the chylothorax, as Jen mentioned before, we started a very low-fat diet for Will. It was thought that by starving the circulation of triglyceride, the lower production of lymph would allow the leak to spontaneously heal. He was limited to about 1 gram of fat per meal, so even healthy low-fat foods like quinoa were off the menu, and finding foods other than rice were pretty much impossible. Cooking meals was much more of a challenge than normal, which is a challenge in itself. Furthermore, we were introduced to a hematologist, and we were recommended a drug for the treatment of the lymphatic malformations. This is called sirolimus, its derivative, or rapamycin. We were provided a paper based upon its use in neonates and anecdotally advised of its potential benefits. We consented to start the medicine and basically were discharged. So now he was eating no fat, he was on a chemo drug, and very quickly our son deteriorated. He started experiencing a fever and chest pain. We read the product monograph for sirolimus. It's called Rapamune, I think was on the box. We advised Dr. Google, and we were convinced that he was having an adverse reaction to the drug. So less than 9 days later, we returned to the hospital to learn that once again, unfortunately, he was septic from another staph infection, probably again from the chest tube site. Not a drug side effect, but from the chest tube removal. After another course of antibiotics, our team was still focused on fixing the leak in the lymph. We were sent to a larger institution for a specialized MR lymphangiogram. This is a 68-hour procedure involving the mapping of the lymphatic system with the hopes of isolating the leak and repairing the defect eventually. So a lymph node in the groin and liver were used as access points. The dye was injected and followed through the cisterna chyli, eventually tracing the lymphatic pathway through the thoracic duct. His MR lymphangiograms showed detailed images of a tortuous central lymphatic channel with the mediastinal thoracic duct on the right side. But because of the severity of it, no intervention or embolization of the duct was planned, and the drug therapy that was recommended for us was just to stay on the drugs at this time.
So this, I'm not going to go into detail because I'm not an interventional radiologist, but we selected these images simply to demonstrate the trajectory of the dye moving through his body at different intervals. We've been informed the images show a leak in the upper mediastinum, and the lymphatic fluid should essentially just be traveling through the body in a straight line like we see in the first slide here, and then it comes back into the circulatory system rather than entering the mediastinal space that we see here. So over these intervals, we see it gradually pooling and leaking into the body.
So after the results of the lymphangiograms, we finally returned home with an extended course of antibiotics now, and he slowly improved. We went back to hospital monthly for follow-up imaging, regular blood work, but unfortunately by the fall of 2020 and the end of the antibiotics, he really started to decline both in presentation and on his chest x-rays. Being on an ultra-low fat diet and in combination with his disease, he was really having trouble maintaining weight. He started complaining of pain in his femur, his right femur, and he again was having declining SpO2. And then that basically led to this same time, almost to the date last year, he had a really rapid decline, and it resulted in an emergency chest tube on his left side. He went to for one of these routine chest x-rays and a visit to hematology on the morning of a Thursday. We're told that things were kind of unchanged and just to keep an eye on him. By Friday afternoon, we were driving up to the emergency department. We were administering him oxygen in the back of the seat of the car while he was losing consciousness. This resulted in an extended hospitalization, and we were transferred soon to an even larger specialized pediatric center several hours from our home.
As parents, the profound limitations of the rarity of the disease were highlighted when we arrived at this special center, only to find out we would have to educate each of the supervising doctors of the pediatric team to the nature of this condition, providing review articles and handing out medical histories to simplify this process. The nurses on the floor used our son as a template for the care of chest tube. He became their model, and I, with no medical background, guided them through their chest tube changes. They took pictures of him in the various stages of changing the box to be used in their binder at the nurse's station, demonstrating best practices. He was draining up to 6 liters of fluid from his left pleural effusion every day, with multiple boxes changed in a 24-hour period. It wasn't until another chest tube infection and antibiotic course that the drainage finally slowed. He spontaneously improved, although no one can still say why for sure. After 50 days of being in the hospital, he was discharged last summer, unable to walk on his own, necessitating a walker to move about the house. He has made steady improvements since. He's now swimming in the pool. He's able to ride his bike. He's currently under the care of hematology with regular imaging of the effusions. And he's recently started a PIK3CA inhibitor, alpelisib, which is usually used for breast cancer. And this drug is promising in its response so far, as I previously noted in our X-ray slide. So needless to say, after 3 major hospitalizations, 70 chest x-rays, 4 PICU admissions, 19 ultrasounds, 7 chest tubes, 3 lymphangiograms, 2 lymph biopsies, extensive and traumatic blood work, 10 echocardiograms, 3 ECGs, 4 CTs, and 9 MRIs. The crazy thing is, as parents, we still do not have an empirical diagnosis of the disease. We know he has a rare condition and that it's referred to as a complex lymphatic anomaly, but we don't have any underlying genetic or diagnostic utility that definitively indicates exactly what type of anomaly. His current working diagnosis is a generalized lymphatic anomaly. All genetic testing to date has come back with no significant findings. We tell friends and family that he's taking a chemo drug, has a problem with his lymphatic system, and there's no cure for his disease. But this really doesn't do justice in explaining his struggle.
So as parents of a child with a disease affecting his lymphatic system, we really wanted to learn more to help our son. But we found the medical system here generally lacks in emphasis on lymphatic disease. In Canada, when you Google lymphatic disease center, there isn't there's very little information available. Links are mainly to manual decompression of lymphedema by physiotherapists, but there's certainly no links to doctors or clinics specializing in lymphatic disease, which kind of leads me to our next slide. You know, the lymphatic system remains one of the most poorly understood and understudied aspects of human medicine. A 2017 article I found indicates that the average American medical student receives less than 30 minutes of lymphatic education during a 4-year academic program. I'm sure all of you know most of this, but I've just put together a little slide. It's called What's Up with Lymph. But basically, just to review, the lymphatic system really has 3 primary functions. The first is to maintain fluid balance. So if you think about the 20 liters of plasma circulating in a typical adult, 17 liters are returned by the venous system. The remaining 3 liters are returned by the lymphatic system. And then it's very important for the absorption of fats and fat-soluble vitamins from the digestive tract. Fats are absorbed from the small intestine by small specialized vessels called lacteals during digestion. These allow for the fats and fat-soluble vitamins, which are A, D, and K, amongst others, from the small intestine. Are taken from the small intestine and transported to the blood, bypassing metabolism by the liver. And the last and most important function is immune function. The lymphatic system produces lymphocytes and other immune cells to help defend against infection. The organs include the spleen, the thymus, the tonsils, adenoids, pairs, patches, bone marrow, and the appendix. The normal flow of So just 1 second there.
Sorry, it's just loading. Okay, sorry, here we go.
Just 1 second. So just to review, normal flow of lymphatics goes from the lymphatic vessels through the nodes and through collecting ducts, and then depending on the anatomical location, through the right lymphatic duct or the left lymphatic, otherwise known as the thoracic duct. With complex lymphatic anomalies, this was formerly referred to as lymphangiomatosis or lymph production tumor. The lymphatic system defects are thought to be the result of congenital errors of lymphatic development occurring prior to the 20th week of gestation. The condition is marked by the presence of cysts that results in an increase in both the size and the number of thin-walled lymphatic channels that are abnormally interconnected and dilated. The condition may involve a single organ system. 75% of cases involve multiple organs. It typically presents by age 20, and although it's technically benign, the deranged lymphatics tend to invade surrounding structures and cause problems due to the invasion or compression of those structures. The condition is most common in the bones and lungs and shares some characteristics with Gorham's disease or Gorham-Stout disease. There are 3 distinct types of complex lymphatic anomalies. The first is Kaposa-form lymphatic anomaly, or KLA. It's the most aggressive and rarest of these disorders. It's diagnosed at younger ages, and the effusions which result often have a higher incidence of hemorrhage. The diagnosis is made by biopsy material that shows the characteristic Kaposa-form spindle cells. GLA, or generalized lymphatic anomaly, usually presents with a multi-center proliferation of dilated lymphatic vessels, similar to a lymphatic malformation. The difference between a generalized lymphatic anomaly and a lymphatic malformation is that it tends to involve multiple sites, including many or all of the following: the bone, the liver, the spleen, the mediastinum, lungs, and the soft tissues, including organs. Generalized lymphatic anomaly may be present at birth, but usually becomes evident during the first 2 decades of life. Gorham-Stout disease is rarer than generalized lymphatic anomaly, and although there may be soft tissue involvement, it is known for bone involvement, where the bone cortex is dissolved. The other name is common for this is vanishing bone disease. Any bone can be involved, but the most commonly involved are the ribs, the cranium, the clavicle, and the cervical bones, although the hip, the humerus, and femurs are sometimes described. Pain is usually from pathological fractures that occur through the weakened bone, and the disease is often diagnosed when the patient is being investigated for a minor trauma, which seems to be producing a major amount of pain. This next slide here illustrates the genetic pathways of PIK3CA, mTOR, the RAS pathways, which are associated with lymphangiogenesis. and that are every day being better understood with respect to understanding the pathology of complex lymphatic anomalies. The research into identifying potential biomarkers and is driving a lot of research into targeted drug therapies. And that's the basis, the PIK3CA pathway is the basis for our son's current medicine, alpelisib. So, the next little bit, we just wanted to go over what happens when a rare disease is encountered and the unique challenges that are presented both for the medical team and the patient as well. The first is the denial of algorithms. So the routine algorithm that's applied to pathognomonic identification of disease in medicine is challenged by rare disease. The diagnosis of our son's disease, like most of these, is one of exclusion. After the initial hospitalizations, we really started to question the repeated attempts to try chest tube drainage. When the end results of the poor chest tube drainage were the same, we just started wondering why we're going down the same road expecting different results. Sometimes could it be something else? On that note, just because it lays eggs doesn't mean it's always a bird. Rare diseases exist. They may not be common, but if you're in a situation where the expected result is not there, pause and take the time to consider some of the things you weren't expecting.
So when you're dealing with a rare disease, you typically have multiple teams involved. Our main teams are hematology, oncology, and IGT. When we're hospitalized, general peds comes in and they manage him daily, and then infectious disease usually steps in because we typically end up with some type of infection. So as well as those primary teams, all of these teams are involved in our care. And this is not unique for a rare disease. Typically, multiple teams come into play when patients are complex. So in a rare disease, we often have a very limited, truly need to collaborate on rare disease and place all their patients together in order to make effective, time-sensitive advances in unlocking the disease. We need to break down the walls and step outside the silos each of us work within and come together to advance. We've encountered great reluctance amongst medical professionals to collaborate with outside institutions, and we've witnessed ineffective communication within institutions themselves. Experts in the field often want to be contacted, and we urge you, when you're at that point in your career, to reach out to others. There is strength in numbers.
So one of the things is that family input is so important. Parents often step in and explain to medical teams what's going on. During our 3 rounds of major hospitalizations, there often appeared to be a lack of communication with each of the teams from each discipline entering our room. Regularly, everyone needed to be brought up to date. We found ourselves repeating things again and again. Rare disease families are best served when they do become their own medical quarterbacks, or at least have the ability to do so. Even though it's tiring, it is just a part of having to deal with having a rare disease and raising a family. One of the other things that's really important is to actually take the time to listen to the patient's history. We've been on the journey and we've witnessed firsthand what works and what doesn't work for our child. Best practices don't really exist. There aren't enough patients with it to come up with those. Patient voice does play a much louder role than other common diseases, which are well searched and have a defined best practice. With our disease that we're dealing with our son, that right now they're finally coming up with guidelines to do just this and move towards best practices. But not every rare disease has these.
So now that we provided a brief outline of the disease, we wanted to touch on things on a more personal level. Due to the rarity of the condition, we as parents definitely understand the inherent curiosity that exists amongst medical professionals. I'm going to briefly outline some of the things to consider that would have made a huge difference in our experience. These are more points made on a personal level from one human to another and should be considered for the mental well-being of the patient long-term, especially when the disease is chronic in nature. One thing that always needs to be remembered is that the child is a child, and they're often scared and confused. The child does not understand what's happening to their body, and they miss the life they once knew. When coming in as a doctor, you need to exhibit sensitivity to this. It should not be viewed as an opportunity to experience your medical textbook firsthand, but rather a chance to learn and interact with a child you can hopefully help. At one point, I was trying to find a pediatrician for my son on the recommendation of our hospital to act as a medical quarterback of sorts, to help me in navigating all the specialists his condition requires. It was during COVID, and I had been turned away by numerous specialists due to the complexity of his case. I thought the best approach during the height of an outbreak would be to have an initial phone consult to see if we were the right fit for the practice. I urged one doctor in particular to begin with a phone call, and they insisted they needed to see him in person. So reluctantly, I took him to the appointment. I gave the medical history and asked if they could help us, to which he replied, no, he's too complex. And we had already heard this numerous times. I asked why he had us come in knowing this. He in turn replied, I'd only ever read about this. I wanted to see him in person. I'm thinking, well, we can do a video call. But he continued on to say he wanted to actually touch someone with the condition. How did that make my son feel when he was going in there hoping for help, like an interest or a curiosity rather than a person, perhaps? It left him more scared and confused for being turned away yet again for being too complex. When you come into a room as a medical professional, please keep it to a limited number of doctors if possible, and take time to ask the patient if they prefer discussions to be outside the room. Everyone who enters the room should introduce themselves. It's very upsetting to a child who's continually had strangers enter the room only to hear repeatedly, I don't know, we're not sure, we're going to think about this. It is also very intimidating to have 2, 5, or 10 doctors surrounding you talking about specifically what is wrong. When initially examining a child, ask them, is it okay if I listen to your heart? Is it okay if I listen to your ears? Is it okay if I touch you? This may seem so basic, and perhaps you've already been taught this, but at the end of a shift or in a rush to get to the next patient, it's often forgotten. And this leaves a lasting negative impact on the child who has seen countless doctors that same day. They have lost so much control over everything they've known, from bowel movements to quiet time, and at least give the conscious child the choice. Also, do not make audible comments in front of the child about their appearance, like you're analyzing them. Rather, take mental notes. They already feel very insecure and out of place, and there's no need to hear all the things wrong with them. And please remember, we can hear you when you're talking in the same room as us. The child also needs quiet time. Being in the hospital is so invasive. You yourself may only come in once during an 8-hour time frame, but understand you're just one of many constantly checking on the child. Not only is the child subject to a multitude of tests and exams, but they're also given very little time to rest as the room becomes a revolving door. At one point, we asked for quiet time between the hours of 12 and 2, no exceptions, because the longer we were at the hospital, the more the anxiety began to build. Who's going to walk through the door next? What tests were they going to subject you to? There wasn't even time to enjoy a lunch or dinner. It was unannounced and constant interruptions. The quiet time needs to be respected for the patient's well-being. If a test must be scheduled during a certain time, then forewarn the patient and they can move their quiet time around. This little bit of control really brings so much peace. Parents need to understand also the significance of the diagnosis of rare chronic condition. These diseases have profound implications on families, and they must prepare for chronic illness, not just an acute phase. Offer supports, whether it be from yourself or connecting the patient to proper support networks like social work or advocacy organizations. It's exceptionally isolating to find out your child has a rare disease, and scary when you feel completely alone with nowhere to turn. Messaging and comprehension are so important. Make sure to communicate effectively and that your message is being understood.
And just as an aside, this really extends to communicating and properly explaining the possibility of a rare disease when you're considering it in your differential diagnosis. Not to be an alarmist, but to prepare the family, who can then in turn prepare the child for the possibility of a life-altering diagnosis. As parents, it's much easier to deal with knowns than things that are unknown. If we know that something may be a possibility, we can prepare our family or the siblings or the child themselves in advance. Surprise is not an effective planning method.
We first learned about our son's diagnosis by accident, by reading his chart. As our son's case progressed, more teams were brought in to try and help manage him. Our room, as I've said several times before, became a revolving door. General surgery, infectious disease, hematology, oncology, dietitians, physiotherapy, and the list went on. It is imperative, and I can't stress this enough, that the teams can enough to remain up to date on the patient's case and care. This must then be communicated to the parents so that they can make informed decisions in regards to their child's care. Never assume another team member has told a patient or caregiver anything. Ask for clarification on issues. For example, has X, Y, and Z already been discussed with you? Do you understand the implications of this? Do you have any questions? provide proper and substantial literature to the patient appropriate to the education and language level of the people receiving it. If language is a barrier, then bring in an interpreter. Perhaps provide information at a basic level for the patient, as well as peer-reviewed articles for them or their family doctor. Our family doctor received all of the hospital reports, but they were out of context without knowing the specifics of the case. We had a lengthy conversation with our doctor to bring them up to speed, which they very much appreciated, and articles would have been helpful during that time. Know your audience and work with them as best you can to be certain they comprehend the information. It may take several repetitions, even to an educated parent, to get your message across. When you're in the moment watching your child suffer, it is much harder to process and understand information, both basic and complex. And checking in daily with parents is not a bad idea, even if it's just to see if any questions have arisen after a night of thought. When we were going through our first medical trial with our son, we asked for peer-reviewed journal articles on the drug itself and how it related to his case. We were given a 2-page article that had limited relevance to his specific case. When we asked for more, we were told there was no information they could give us. There's nothing else they could present us with, which seemed mind-boggling at the time. Again, it's so important to know your audience and don't discredit these requests. If at the time we had known what his condition was, we could have most certainly found more information. That was my job as an academic research librarian, hence the importance of properly communicating. We were also often talked to in code, such as this is a marathon, not a sprint. In our minds, we knew that since being away from your family for 50 days and still running a business most certainly felt like a marathon. We did not realize it was a lifelong marathon. We assumed they meant it wasn't a sprint, as in not a week-long stay at the hospital. We thought after the longer stay, he would be better. The messaging presented to us was, we're going to fix him. After the stay, he'll be better. We heard this several times, meaning it was more damaging when we realized there was no fix. It felt like there was a big secret everyone was in on except for us. It is okay as doctors. It really is okay to say, I don't know. I'm going to look into this and get back to you. It's actually more respected by the patient to hear that than something unrealistic. So to summarize, just be clear, concise, and present all the information in the format the caregiver is able to understand. And do not sugarcoat the truth. Sometimes the truth really, really hurts, but don't try and make it better. Whether that be a pamphlet, a peer-reviewed article, or spoken through an interpreter, communication is key. We as caregivers have heavy decisions to make, and we need proper guidance, evidence, and support, both medical and emotional, to foster sound decision-making with respect to our child. If a parent or caregiver is overwhelmed or unable to understand, sequestering a patient advocate from a group such as All Stripes or specific to our disease, the LGGA, may be a wise idea. So in closing, we would like to just say, as doctors, you may find yourself faced with the challenge of decisions we would never thought we would have to make. Rare disease was never on our radar before this happened. And we must all work efficiently together, clinicians across disciplines, researchers, and families, without judgment, walls, borders, politics, and with the best interest of the patient at the core of all of our efforts. Thank you so much for listening, and we will be very happy to take your questions.
Thank you so much, Jen and Kevin, for your incredible presentation. I think that I speak for everyone when I say that some of the most important lessons come from parents and the patients themselves, and that's what this event is all about. So thank you very much for sharing this. And as you mentioned, any questions, Greg will take them and direct them towards you, or if someone wants to unmute, you can do that as well.
So while we wait, I do have two that I received. So they're long, so I'll just summarize them. One of them was just asking about the learning curve and learning about the disease and physiology, whether you had a background, either something similar in the sciences, and how you went about learning about the complexity of the disease.
So I mentioned in the presentation that I'm an academic research librarian, but I was in the arts, so I did not understand any of this. Kevin has the science background, so I would find the information and then he would explain it to me, and that's how we worked together.
And the other question I had was in relation to the quiet time that you referred to. How do you strike a balance between, because the disease is rare, that I'm assuming that it is important that medical professionals learn about it through the patient. How do you strike a balance between giving them really that quiet time, but also making sure that they can still learn from it, and if they have future patients later on, to have a better understanding of a similar disease?
Yeah, sure. So, I mean, I think the difficulty is, at any of the larger institutions that we're at, most of them are teaching hospitals, right? So you expect there to be that level, and it's totally understandable as parents. The problem is just, I think sometimes, whether it's the students or even the whole system, from essentially shift change at 7:30 that morning, going through until about that shift change at 5. That's when most of the action Monday to Friday happens within the hospital. And it was kind of funny because I'm working during the week, and I would go up on like a Thursday afternoon to take over Friday, Saturday, Sunday. And I saw nobody. I had no problems with quiet time. All right. But when it comes to the week, the days where I was there, like Monday to Friday, the few times, it was insane. It's just
it's constant,
in and out.
constant.
So whether like, for example, he was on meds, a lot of meds every 4 hours. So there would have to be constantly the nurse coming in, vitals being checked every 4 hours or less, a different outfit. So
at the one institution, sorry, I'm going to interrupt. At the one institution, vitals were done every hour, even during the night. They would wake you up in the night and say, your son's doing okay. Well, that's great, but I need sleep, So you can definitely strike a balance. We put a sign on our door that said 12 to 2, do not come in unless it's a test, an exam, MRI or something that you can't reschedule. We are more than willing to talk to anyone and educate anybody about him, but he needs peace. He was starting to get so anxious. Just who's coming? It was constant all the time. And it's just not healthy for his well-being. You have to almost decompress when you come home from the hospital. It's so quiet at home in comparison with 4 kids, right? Yeah. So
the other thing too, it always baffled me is that how, in a way, we kind of expect people to get better in a hospital, because you don't get a chance to rest. Like I would look forward to coming home after driving 2.5 hours, 3 hours, after being in the hospital for time, just so I could go to bed and get 4 or 5 hours straight. We had a private room. We were very fortunate. We're not, we weren't in a ward room or anything like that. And that was, but just with the constant interruptions of sleep, it was remarkable, how tired I was, just trying to deal with that. So yeah, so it is definitely a revolving door. Just, I think the best thing is just to be mindful that there's, probably an exhausted kid in that room or an exhausted patient from all the traffic.
Mm-hmm. And I created handouts for doctors or whoever came in, students, anyone. And it was basically a whole summary of his history, because I was repeating it again and again and again. And I just said, here, just there you go. And then they took it back to their supervisor and they could review it, and then come back to me with any questions. But it is an exhausting process to go through.
There are no additional questions. I just wanted to say thank you again, and I wanted to also thank Dr. Steele, who I believe is also here, who put us in contact. So I just really, really appreciate that you guys putting together such a wonderful presentation for us students. And I'm just gonna I'm gonna share my screen one more time, just so that everyone can see the website that you can go to get more information about Will's Power. And is there anything else you guys wanted to add, or anywhere people can reach you aside from this website?
I just see one.
We have one question.
One more question.
Okay.
Oh, yeah, that's a good question.
The question is, what does your son think about his experience so far within the medical system? You could ask him directly. He's upstairs.
Yeah, I think he knows that everyone's trying to help him. He has been treated very, very well by everyone that visited him, and they truly are trying to help. But there's trauma, there's PTSD associated now. The constant barrage of tests and talking to people and hearing what's wrong all the time, it just it's damaged. But he knows that the doctors inherently are there to help, and he has trust and faith in them, that although they might not have all the answers, they're trying. They really are. Their hardest they are. So he has mixed emotions about it, I suppose. Yeah.
Well, that's a very important question, and I'm glad it was asked, because I also think that it's very difficult, I imagine, for you guys, but also it's hard sometimes to understand exactly what the patient themselves is experiencing. It's not always communicated, and I really appreciate, again, and I think it speaks to the name of this your organization, that it is really an empowering story. Will's Power. I really like that name, and so hopefully we'll be able to share this story with anyone else who feels like they're going through something like that. And definitely it has encouraged us as for research purposes, researchers, and for healthcare professionals. It's an important message. I'm just gonna finish by changing the slide. So just to give everyone a brief overview about Rare Dig as well, you can reach us here at our website. And if you want to be in touch with Jen or Kevin, do you have like a contact on your website if anyone wanted to reach out to you?
Yes.
Okay.
Yeah, and we'd love to hear from anybody,
Especially researchers.
Especially researchers, yeah, but anyone really. If you think about something in a couple weeks' time, we're here. And thank you so very much for this opportunity.
I hope it was good. Hope you enjoyed it.
It was excellent. So thank you, everyone. Thank you to the Rare Dig team and the Pediatric Interest Group who helped us put this together. And thank you to Dr. Steele for connecting us and always being our mentors throughout all these events. We really appreciate the support.
Yeah, thank you, Kim.
It's all you guys. You're wonderful. And thank you. I've got Greg behind me here somewhere. Yeah. Thanks, guys. You're all amazing. And I didn't want to say anything, but you're all really wonderful.
Thank you so much. So I'll end the meeting here. And if you want to